All right, perfect. Well, I think we'll get started. Hi, everyone. Thank you guys for all attending this session. We have a star-studded lineup talking about sinonasal cancer. We have presenting fellows and mentors. So we have Chris Knoll from Ohio State University, mentored by Dr. Kyle Van Koevering. We have Dr. Michael Shee from the University of Toronto, mentored by Dr. Eric Montero. We have Dr. Nadine El-Hadi from the University of Miami, mentored by Dr. Karina Levine. We have some senior discussants, Dr. Marilyn Wang and Dr. Eric Wang from UCLA and UPMC, respectively. And a special thanks to Dr. John De Almeida from the University of Toronto for organizing all of this. I know we had some issues with dates related to the North American Skull Base Society, but we found a date that finally worked for everyone. So take it off, John, and thank you so much. And at the end, I'll remind you guys when our next session is as well.
Thanks, Tony. And on behalf of the Skull Base section of the American Head and Neck Society, welcome to all the clinical fellows, and thanks again to the panelists and the discussants. I'm not going to take too much time here, but we're going to jump right into cases. I think we have three very interesting cases led off by Dr. Noel. So, Chris, why don't you take it away?
Thanks for the opportunity. For discussion today, we have Mr. G, who is a 57-year-old gentleman, otherwise healthy, with a 26-year history of multiply recurrent adenoid cystic carcinoma of the sinonasal cavity. He's been treated at several centers across the United States. So to briefly recap, his journey started in 1999 when he developed an ACC of the maxilla. He underwent a infrastructure maxillectomy and adjuvant neutron therapy. He did well for about a decade until about 2009 when he presented to a second center and got revision surgery. The notes on that are a little bit sparse, but we do know well that he did well for about another decade until about 2018 when he developed a second recurrence in the maxillectomy bed with orbital and masticator space extension. He then went to his sort of third surgical team, where he underwent a total maxillectomy without orbital exoneration and reconstructed with a fibula free flap reconstruction. This was an R2 resection with positive margins along both the orbital floor and pterygoid plates. The imaging done about 2 years later in 2021 showed that he had a soft tissue prominence in the posterior left nasal cavity at the pterygoid plate, masticator space, and orbit. This was observed. He later developed an isolated lung met and underwent a reg resection in 2022. In 2023, he developed some hardware exposure and a bit of a cutaneous deformity. So that the hardware was removed. He had a second free flap, a radial forearm done at that time, but the residual disease in his skull base was undissected. And then he finally had a biopsy done later that year by a rhinologist, which confirmed recurrent intermediate grade adenoid cystic carcinoma. So that brings us to kind of earlier this year, where he presented to us for really kind of a second opinion, and he and really just seeking further treatment options. He was really suffering from severe facial pain, ectropion, and worsening diplopia, though his visual acuity in that eye was preserved. I think the tumor is best captured with MR. So starting with the coronal, he's got a recurrent tumor in the left orbit that involves the rectus muscles and lacrimal gland without intracranial extension. There's a second component at the pterygoid base that extends into the sphenoid sinus and infratemporal fossa, kind of bulges into the nasopharynx. The tumor involves the foramen rotundum below the skull base and kind of encroaches on ovale, but there's no overt sort of intracranial or cavernous sinus extension. He's had we had a PET done as well, which sort of redemonstrates this large hypermetabolic exophytic tumor at the nasomaxillary junction. Notably, though I don't show it here, there's no evidence of any distant or metastatic disease. So we thought this was a good time to bring it up to sort of turn it to the discussants. And I guess we have a couple questions that we prepared just to shape the conversation a little bit.
Chris, maybe to sort of facilitate discussion, Can you bring up your imaging again?
Sure.
And, and then we'll turn it around to, we'll start um,
I just
with
paused
our
it at a good spot.
faculty
Uh,
mentors and then turn it to our senior discussants. Maybe we'll start with Dr. Levine, if that's okay. Your thoughts on resectability, and we'll go around the table.
Yeah, this is always, an area that's going to be a challenge because, resectability at outright cystic carcinoma is, you know, kind of uh, variable, right? Um, there's great studies to show that, gross total resection and getting decent margins is going to make a difference for you. And that even in some cases, close margins are still going to have very similar prognosis. I think the real challenge here is that you don't know how much perineural invasion or skip lesions or other things you have. But in theory, this is a still a resectable tumor, at least by what you can get access to. It hasn't gone completely into the skull base. It hasn't gotten into any of the areas that you really can't get to. But I do think that I would hesitate to say that you're going to get a gross total resection on it just because of the nature of this disease.
Dr. Montero, your thoughts on um, resectability of this, and are we prepared to accept positive margins here?
Yeah, Chris, nice to see you, by the way, Chris.
I see you.
Yeah, can you just show the stuff in the orbit again? It looks like the tumor in the orbit's probably gone in through the infraorbital fissure. It's hard to tell or where the inferior orbital fissure used to be. Is that just in the apex there? Is there anything
I think
forward?
it's all contiguous. Like it looks sort of like two separate masses, but I think they are kind of contiguous with each other. But
So, I mean, I guess the way I would, I agree with what Karina was saying. I mean, he's got incurable disease. He's already had metastatic disease to his lungs. So, to me, this is all about how do we try and maintain him going. He's gone for almost 25 years now, and how do we maintain him going as long as possible with the least amount of morbidity possible? That's kind of how I think about this, because this is no longer a curable tumor. So anything we do here, regardless of whether it's surgery, radiation, or chemotherapy, is all going to about controlling things for as long as possible. So that's kind of, I don't know what the conversation you was that you framed with him, but I suspect the reason he's coming to you is because currently his quality of life is horrible because he's got a lot of pain. So really, at the end of the day, what he's probably looking for is treatment of his pain, and that can always be tricky because it's hard to know what's going to be causing his pain. I don't think you can't get that orbital apex disease out without taking out his eye. And if he's got a functioning eye and he's got incurable disease, I'd be reluctant to go down that road, knowing that I'm probably not going to give him long-term disease control, as opposed to someone who has a non-functioning eye that's very, very painful. As we all know, that's a little bit of a different scenario. So for me, that orbital apex involvement is very hard to not only get out fully, but you can see it's funneling towards the apex. That's basically impossible to get out. And not only that, if he's got visible, good vision preserved, I'd be reluctant to do that. So for me, this is very difficult because the symptom I'd be wanting to treat is pain, and it's very hard to know how we would address that surgically. I agree with Karina. The lower stuff down is technically resectable. You're going to have positive margins for sure at foramen rotundum and those various other, in my opinion, even if they look normal radiologically. However, I sort of wonder whether the source of his pain is potentially coming from either branches of V2 or V3, which is not uncommon in these multiply recurrent tumors. So I don't really have a great answer, Chris, because I think the treatment here is really to manage this guy's pain. And I don't know if you and Kyle have a better idea of where it's coming from, but that's the difficult part for me to know. And I wouldn't take out his eye at this stage unless it was non-functional or the eye itself was giving him a lot of pain.
Kyle, Dr. Van Covering,
Yeah,
this is probably your case. So what did we do here?
yeah. So both great points from Dr. Levine and Dr. Montero. It's just even understanding this guy's disease history was like reading a novel. And fortunately, he was extremely well educated. And so there were so many complicating factors. Prior neutron therapy, and what does that mean now, 25 years later? All of this pain that he was having, and I totally agree with you. the infratemporal fossa and the pterygoid involvement was going to be tough surgically, but the apex and the orbit was really the crux of our discussion. And he had a lot of pretty severe pain. Part of it, I think, was an infected mesh that was there. He had severe ectropion and was beginning to have more and more dysfunction with worsening diplopia. Although the acuity was intact, the orbital pain was starting to be debilitating for him. As we talked more, I realized there was some underlying opioid addiction or dependence that he has been dealing with for over a decade, as all of his chronic treatments have included opioid therapy along the way. And it was really difficult to distinguish what was flap, what was tumor, what was infection, et cetera. So that's why we got the PET scan to kind of help delineate that to some degree. So we had a long conversation, multiple clinic visits, just like you said. And then, I ultimately told him that I thought that if we entertained a definitive approach, this was the last shot at doing it. If we were going to entertain surgery, it would have to include an exenteration, infratemporal exenteration, nasopharyngectomy. And at best, my plan or goal would be an R1 resection for this. But there is very compelling data, as Dr. Levine highlighted, that an R1 resection with adjuvant radiation has durable local disease control in the 5 to 10 year range, looking at 75, 80%. And so basically what I told him, to your point, Eric, is if we're going to do it, the goal is to try and buy you 5 to 10 years. But I don't know if you're going to have a metastatic focus pop up, and I can't guarantee you won't have disease that progresses intracranially. So that's where we started the conversation.
It's interesting, Kyle, as you said, like with the recent data, like I think it was a SEER study, right, which looked at sort of R1 resections in T4B tumors followed by postoperative radiation do better as opposed to upfront chemo radiation. So we're going to probably be having these conversations a lot more moving into the future. And I think both you and Karina alluded to that. And no, that was a good clarification, because you're right. Like if the pain is coming from the eye, then that would potentially palliate him to some degree. But yeah, I agree. It's kind of his last shot. And what did your radiation oncologist think, out of curiosity, in terms of room for additional radiation?
So that was my first question, because that data is only valid if you can give definitive or fairly definitive doses of adjuvant radiation. And so we had a long discussion. We tried to track down the neutron treatment profile from 1999, but that was a futile effort, unfortunately. So this evolved, fortunately, over about a month and a half of discussion points, because it was a slow growing tumor. We had time to really work all this out. But they said, 25 years later, particularly if we were going to be putting a free flap into the cavity to bring fresh vascularized tissue, they were willing to give him definitive radiation with protons, which is also another discussion point about what type of radiation you'd want to entertain here. And so because that package, the full package was available on the table with R1 and definitive protons at full dose, I thought it was reasonable to at least offer him definitive resection followed by adjuvant treatment.
I think the point is worth making here that just for the fellows on the call, neutron radiotherapy is something that has, to the best of my knowledge, largely fallen out of favor, but had its kind of time in the sun, where some of the side effects were quite significant locally, and this is part of the reason why it's fallen out of favor. Feel free to correct me if I'm wrong, any of the panelists on the call, but that would be a consideration here, the local toxicities of further radiation. Maybe to the senior discussants, any argument to not proceed with surgery here? I think we have arguments in favor of an orbital exoneration, mainly for symptom palliation, and possibly achieving an R1 resection may give him some local control. Dr. Wang and Dr. Wang, any thoughts on non-surgical approaches? Maybe do we have some alternate approaches we could offer here?
Well, I think you've done a great job of outlining, discussing with him his goals of treatment, and you're trying to buy him some more time. He's not probably curable in the long term, but we know that adenoid cystic can be indolent. I would potentially explore some of the clinical trials out there. You could talk with your medical oncologist, see if there's any immunotherapy. I don't think they've had great results, but at least it might be another discussion to have if he were really against having surgery.
That's perfect. And I will add, he's, like I said, very well educated and well prepared and knows this disease. He actually came asking that question. He had a trial or two that he had looked at that was actively recruiting. We talked with medical oncology about that as well. I'm happy to go into detail there.
Kyle,
Eric, your thoughts?
has there been a change in the pathology over time?
I think originally it may have been more of a low grade or cribiform, but now it's being read as intermediate grade.
Right. So, I mean, that's more consistent with the history, right? Whether you do the formal MD Anderson ACC 1 and 2, or you just look at the solid pattern of it versus not. But given his long, drawn out course, I mean, 20 something years, I think that you make that assumption that it was actually low grade at first and it is getting more aggressive, you know? So I would say that if he does anything besides pure palliation, as Eric suggested, or maybe mesh removal if you really think the mesh is infected and causing some of the pain. But if you really are trying to manage that orbit, the likelihood is with this much disease along V2, that orbit with a transition in its pathology is likely not going to be a very functional orbit for very long, pain or no pain aside. So I think most centers, and I'm sure you guys did this, Kyle, you would have gone in some sort of Oncomine sort of panel on this to
Yep.
see if he has any targetable options. I'm sure you went, no?
No, we did, and it was negative.
Yeah. I mean, so I would say, then that's kind of the pattern with adenoid cystic, right? And that's been the challenge with most of these trials is that in truth, we have very, very few targetables. If you lived in Italy or Japan, I guess you would think about carbon ion, but again, that would sacrifice the eye just in a different way than sacrificing the eye surgically. And it's unclear if that would actually result in any more or less pain. And I think the radiotoxicity to the frontal lobe and to be truthful, the sparing of the contralateral eye becomes a little bit of an issue. Chris, if you could scroll back for me a little bit on that orbital apex on either slide, doesn't really matter. Posteriorly, if you could.
Oh, yeah, sorry. Skipping a little.
Yeah, you're close. I mean, you're sort of knocking on the front door of the cavernous sinus, at least in my view of it. It's not invaded yet, but you really do. I mean, if you think about quality of life, preserving his right eye has some value too. I think I would probably either go complete palliation, like pain control palliation, which seems, like a very reasonable option. I think that the trial options are pretty limited, or I think Kyle's making the right. If you're going to make a surgical decision, it's the right decision. Free tissue transfer in there gives you some degree of protection. The neutrons are a long time ago. As I recall, John, most of the side effect profiles were pretty early, like in the first 3 years from neutrons. And I think the only place left in the United States that gives it is University of Washington. So I would probably, I have to admit, I probably would fall under Kyle's if I thought the orbital pain was the significant driver, because I do think in some ways this orbit is probably past the point of doing much except for literally just palliating it.
Yeah, and just to add to the neutrons, again, correct me if I'm wrong, everybody, but I think there was like the 90s was the time when we thought neutrons was the secret to adenoid cystic carcinoma, right? And then but the data didn't, because it wasn't routinely used for other pathologies. It was really commonly used for adenoid cystic, but I think as more data has come about, it hasn't really shown to be much beneficial. And I think speaking to a colleague from Austria who does carbon ion, and again, I think carbon ion hasn't been particularly amazing for this disease either. I think it has been quite helpful for other challenging diseases that we face, like mucosal melanoma in particular has had some pretty decent results with carbon ion. But again, I could be wrong, but I don't think it's been particularly amazingly helpful for adenoid cystic when compared to other available usual radiation treatment options that we have.
So I think, Eric, there's a little bit of controversy in that. If you were to ask the Italian group, I know we're at our time for this case, but the Italian group, it has largely moved to carbon ion for almost every sinonasal adenoid cystic carcinoma now. And it's really kind of their primary treatment algorithm as an ablative radiation source, not adjuvant cleanup, but as an ablative source.
Primary treatment,
yeah. Yeah, I think that it may be like neutrons too. I mean, it may, as you say, the data, right? Like the data is still maturing. And we can see that the challenge here is that we really need long follow-up to really understand how these patients do. And that's a challenge of many sinonasal disorders, but this one in particular.
All right, we're just to sort of really quickly wrap up with this case, and Dr. Vancouvering alluded to this because this is important, even though we're primarily a surgical group here. Kyle, can you quickly talk about mutations and your conversations with MedOnc? I will say that there are some mutations and targetable agents here, and I'm not a medical oncologist, but we know about MIB and FIB
Yep.
fusions.
Notch
There are, of
mutations.
course, notch mutations, and there's data around notched targetable agents, and of course, TKIs with lenvatinib. So, what were your, just to wrap up, what were your conversations with medical oncology around potential targets?
Yeah, the short answer is we did not detect a notch mutation, and our medical oncologist, he basically said that of all the trials that are out there for adenoid cystic, not any of them have really panned out very with a lot of positive results to date. There's some tyrosine kinase inhibitors and some other trials that are ongoing. I talked to the patient about that option and frankly told him that it's very hit or miss. And he frankly wasn't willing to take the risk because his disease seems to be progressing a little more quickly now. And if we give him 6 months on a tyrosine kinase inhibitor and now it's in cavernous sinus, the conversation changes a little bit, frankly. And so he actually, after a long discussion and talking about his orbital pain, really wanted to move forward with surgery because the medical oncology landscape just did not seem very promising as a definitive option.
Okay, great. Maybe we'll move along. Dr. Shea will present the second case, and Dr. Montero, his mentor. Michael.
Great, thank you. So the case I'm presenting is more so a skull-based case, and hopefully a lot of interesting discussion points to highlight here. So it's a 31-year-old male who presents with a left TMJ lesion. Diagnosis preliminary is a calcified chondroid mesenchymal neoplasm. Essentially noticed swelling over the TMJ area for about 11 months. Initially had a few non-diagnostic biopsies, only had some associated jaw pain, xerostomia, and oral fullness, and otherwise no upper airway digest tract symptoms. Imaging, which I'll show in a second, showed a lesion in the TMJ involving the middle cranial fossa floor. And there was initially concern for possible sarcoma, prompting further biopsy, which clarified the diagnosis. So I'll show you the imaging here. So you can see this soft tissue lesion surrounding the TMJ capsule. And on the coronal, you can more clearly see its skull-based involvement extending into the middle cranial fossa floor on this image. And on the patient's MRI, you can see the similar lesion enhancing the joint space there, encroaching on the middle cranial fossa, but sparing the dura. And then in the axial imaging, you can see that it gets very close to the petrous horizontal internal carotid artery here. And so before moving on to the discussion part, I just want to highlight that the initial biopsy came back with some features less concerning for malignancy, with no atypia, no mitotic activity or necrosis, and the preliminary diagnosis, as discussed, was a calcified chondroid mesenchymal neoplasm. In terms of discussion, I had a few points to highlight here, and then I can move on to the rest of the case if there's no further points. But essentially, are there any additional concerns about the preliminary pathologic diagnosis given the extent of the lesion? Would anyone consider any radiation in the role of management of this lesion? And then since we're talking about surgical approaches for treatment, would anyone have any recommendations for any approaches that would achieve an en bloc resection? And then additionally, given the location of the lesion and function, any considerations for reconstruction.
Okay, Michael, let's break there and maybe get some input from our faculty members. Maybe let's start with Dr. Vancouvering, if that's okay. Obviously, not your run-of-the-mill
No,
skull-based tumor, just a very weird and wonderful
we see
sort
like
of.
20 of these a year. I don't know what are you guys doing in
You
Canada?
guys, you guys are the highest volume center in the world for this, for sure.
Yeah, no,
Um,
definitely not.
yes. So this is a benign, sort of locally aggressive pathology, obviously with resectability issues on imaging. Let's say you are going to offer this patient surgery. How are you thinking of approaching this, Kyle?
Yeah, great point. And maybe can you pull up the axials down into the window there? Um, and so for me, this would obviously be an open approach where I would do a preauricular and extend that into at least a hemicoronal, if not a full coronal incision, depending on some of your cosmetic preferences on how you like to make that incision. And bring that down. It looks like it's going well into the parotid as well. And so you probably are going to need to dissect the facial nerve in order to help deliver this tumor and get the TMJ exposed through a preauricular route. So sort of defining that frontal branch and the upper division of the facial nerve may be needed here. So I would probably extend that into some degree of a modified Blair incision to get the exposure. And then, in a combined fashion with neurosurgery, this is going to involve a subtemporal craniotomy to try and get around this tumor en bloc from above and below. And you'll have to take a cut across the condyle or through the ramus, perhaps even. I can't remember how far down the TMJ it goes there on the coronal. Once you have that mobilized, the deep dissection is really the hard part where the carotid comes into play. And so it's really a slow dissection, probably working over top of the tumor to get to the petrous segment at the floor of the middle fossa, trying to peel dura the whole way. That's a tough dissection, no doubt about it. But that would be the approach I would probably take.
Dr. Montero, can we get this out en bloc, you think? In one piece?
You're gonna try, but yeah, I mean, I think you probably can, John. It's gonna be a little bit challenging, but I think you can. I agree with Kyle that that's how I would approach it as well. This wasn't my case, but I think a hemicoronal probably would be enough here. Sometimes you have to extend it a little bit over just to get enough mobility of the skin flap. Neurosurgery could go from above to sort of clear the middle cranial fossa floor. It looks all extradural on the imaging. Yeah, I agree with Kyle. It looks like it's quite a lot into the parotid gland. So I would dissect out the facial nerve and particularly just mobilize the upper branch because it'll all be deep to those upper branches. I think some of the zygoma has to go anteriorly as well. And then the carotid could probably be approached through the neurosurgical approach of the middle cranial fossa floor because that will give you some exposure to the petrous carotid. And then similar to what Kyle said, you can also approach the cervical and parapharyngeal carotid through the neck just to kind of protect that. So I agree with what he said. And I think, an en bloc resection is going to be doable. Positive margins might be risky for microscopic positive margins, depending on how close it is to the facial nerve on the deep side of the facial nerve. So I'm not sure what you encountered, John, when you did the case, but I suspect it'll be a little close there.
And maybe from our senior discussants or Karina, any other approaches other than what Dr. Vancouvering suggested, preauricular to a hemicoronal or full coronal? Are there any other approaches to get to this?
It would not go endoscopically.
I agree. I think the concerns are definitely the carotid and the facial nerve. And I think that approach is probably the best and the safest so you can identify those structures and try to preserve them. I would be concerned a little bit about the pathology. It's not a common tumor that we see a lot, and it wouldn't hurt to maybe send it out for another opinion just to make sure it's not another rare type of mesenchymal tumor because or it could be sent out, after the tumor's out. That might actually be more helpful when they have a lot of tissue to look at.
Yeah, that's generally what happened, Marilyn. I think John can speak to it because I think it was his case. But we, all the sort of sarcoma type lesions basically get regionalized to one center that both John and I work at, just because the pathologists have basically been regionalized for our entire province to the one center. So I can't remember whether the initial biopsy, John, was read at Sinai or whether it was the post-op, but that's exactly right. The pathologist will often just reflexively send it to the sarcoma center for the reasons that you spoke about, is just that these can be really challenging. And sometimes, even after the post-op and they have a lot of tissue, they always can't properly characterize these things 100% either, right? They'll sometimes hedge on what they think it is. But
Yeah, these rare pathologies are tough, but your radiation oncologist is going to want to know. They're very reluctant to radiate anything that's benign.
Dr. De Almeida, I think this tumor has some fusion profile that I can't quite remember, growth factor something or other. Oh yeah, okay, there we go, at the bottom there. Does that, I have no idea, to be honest with you, is that amenable to any targeted therapies?
Yeah, that was a good question, and then we actually had one of our sarcoma med oncs sort of enter into the discussion before we proceeded with surgery, which we did. So this is amenable on clinical trial to what are called CSF inhibitors, or colony stimulating factor inhibitors. There's some data on that in the clinical trial space. These tumors are actually probably seen a lot more by oral maxillofacial surgeons, and so it's probably not in the average sort of skull-based surgeon's wheelhouse. It's kind of rare, but they're not as rare for, I think, for oral maxillofacial surgeons, and the data generally supports wide local resection where possible, and where concerning margins, there is a role for radiation treatment to minimize the risk of local recurrence, particularly in areas where it's close to unresectable structures. So that's kind of where the general thinking is with this approach. Maybe we'll switch over to Eric Wong. Your thoughts? I know you have an interest in reconstructive surgery. Do we need to reconstruct this? What do you think? How would you approach this, and what would be your considerations here?
I think I would in a 31-year-old. He's obviously going to have significant shortening of his ramus. I mean, it's almost, yeah, that's a beautiful cut. Thank you, Michael. I mean, that you're going to shorten his ramus by 3 or 4 centimeters. So it seems like he will have long-term dysfunction of his jaw, of his mandible, excuse me, if there's not a reconstructive option. It looks like it's going to be extradural, but that's going to be close as you go through it. It's going to need sort of almost a petrosal approach as they come down from above. And then, obviously then there's going to be that portion of the temporalis that you're going to sacrifice as it attaches, all of the muscles of mastication in that space. You're going to have a pretty large dead space. So, John, you are definitely a better reconstructive surgeon than I, but I would guess that you're going to try to do something to restore some of that height, even maybe with one of those TMJ prostheses that oral surgery sometimes uses for very recalcitrant situations. I guess the question is whether you do it at the same time as your resection, or if you go back and do it later. I'm guessing it'd probably be best because you're going to come from above and below, and it's really quite an impressive approach you'd have to take for it. I was trying to contemplate if there's any way to not have to do a full hemicoronal to a Blair like incision, but it just feels like the parotid has to be dissected to get this clear. So I don't know that there's another option. At first, I was trying to contemplate if you could get, if you just pop up, Eric mentioned you're going to have to take probably the zygomatic arch, if that will allow you to rotate enough out that you could make an inferior incision like through a cervical approach and then deliver it without the parotid. But it sure seems like the parotid's directly involved with this. Is that accurate, John?
Yeah, it definitely was, and that's kind of how we approached it. Michael will kind of wrap up the case in a second, but I want to just address one other issue, and maybe with Dr. Wang, Marilyn, your thoughts. This is very close, as you can see on the CT, to the carotid. What are your approaches here? How do you prepare for for potential carotid injury? Are there any things you do in terms of investigations, either preoperatively or considerations intraoperatively for carotid management?
Yeah, there's things to consider. He's a young person, so you do worry that he doesn't have a lot of collateral if you do injure the left carotid. But you certainly could do angiogram, you could do a carotid balloon occlusion in advance just to see if it were necessary. I don't think it would be, but it certainly wouldn't hurt to do an angiogram and see what the circulation looks like.
And intraoperatively, let's say you get into it at the petrous carotid, which is where it's very close.
Yeah.
What are the options here? If we injure the carotid intraoperatively, we're very close to the horizontal petrous carotid, taking the tumor out.
Yeah, I think you have to be prepared for that to harvest some muscle, some kind of a graft to put there. And fortunately, with an open approach, you have a little bit more access. I think you can plug it, so to speak, a little easier than endoscopically. And then, of course, he would need an angio post-op just to make sure there wasn't any embolus or a clot there.
I agree with Marlene. I mean, you definitely need to get immediate control, probably through directed packing. And then subsequently, angiography is going to be the answer because actually, I think in most 31-year-olds, they tend to have pretty reasonable collateral. Certainly, pediatric patients have really great collaterals. So they can sometimes tolerate quite well the sacrifice. John, did you consider like reflecting the temporalis down and then actually drilling the floor anteriorly to give you even more access width, like in this cut that we see here?
Yeah. So maybe
Really?
Michael, why don't you show the pictures of what we actually did? We
You could
did.
follow the temporal fossa, right? And actually remove some of that bone to give you more access to the anterior portion of the petrous.
That's right. Yeah, we did. I mean, we did essentially neurosurgery came in to do a pterional crani, and as Kyle mentioned, he needed a subtemporal sort of craniectomy to get rid of the disease that was extradural. So, Michael, why don't you show kind of how we managed it?
Sure, yeah. I'll highlight some of the points everyone mentioned. So the hemicoronal Blair and then the neck dissection incision. This is the final resection. We have basically a total parotidectomy. We mobilized the facial nerve and we did a transparotid approach into the TMJ. The pteronal approach, subcranial craniectomy is shown here. And then we did take essentially the posterior part of the mandible, just a vertical osteotomy through the sigmoid notch down. And some of the other points that I wanted to highlight was obviously occlusion is important in this case, and MMF we performed with rapid arch bars, which you can see here. And one of the learning points we had was you can't mobilize the TMJ when the patient's in MMF. So you have to take the patient out of MMF to do your cuts, remove the tumor, and then go back to MMF for your reconstruction. I think Dr. Montero mentioned taking out part of the zygoma. So we did also take out a segment of the lateral zygoma for access from a neurosurgery perspective. And then we, in terms of managing the infernal carotid artery, followed it from the neck through the peripharyngeal space up to the skull base for not only control during a resection, but as we mentioned, in case there's any concern about injuring it at the petrous intracranial portion. And in terms of reconstruction, we performed a chimeric scapula tip myogenous latissimus dorsi free flap. So you can see the scapula tip here sitting, reconstructing TMJ with the tip into the TMJ fossa. And then the latissimus dorsi was used to cover. We had a free bone graft to reconstruct the zygoma. We mentioned and discussed previously about these custom TMJ prostheses, which you can actually modify them so that they don't need to sit specifically in the glenoid fossa, but you can actually abut them against, for example, the zygoma as well as the cranium itself. But the concern was given that medial margin and potential need for radiation afterwards, we want to reduce the risk of any hardware complications associated in that region. So that's why we chose to go for a free flap reconstruction. And just to end the case, I can show you the post-op imaging here, which shows some of the structures that we've reconstructed. So you can see here that that's the zygoma free bone graft. As we go down, we can see the scapula tip on the posterior mandible there.
So John, it looks like you just brought the scapula a little bit forward so that it's sitting below, floating below the middle cranial fossa floor that wasn't resected. Is that right?
Yeah, that's right. We buttressed it against some residual
Yeah, right there.
sphenoid bone. That there is a thought around doing a custom TMJ prosthesis, but the concern there, obviously, in patients who, if they do get radiated, that we'll see a hardware complication, almost like that first case that we saw. And there really is still a possibility of coming in secondarily down the road and putting in a secondary TMJ implant. The other thing in our center, custom TMJ prostheses take 3 months to develop or to get them manufactured, and this was progressing. In fact, it progressed from imaging to surgery, and so there's that's a consideration as well. But when you put the patient in MMF for a period of 4 to 6 weeks, you almost let them create a pseudoarthrosis there, and they kind of scar into place, and their occlusion actually prevents migration of the scapula into the middle fossa because their bite prevents that scapula from actually pushing intracranial. So that was kind of the thought around that. So maybe in the interest of time, we'll move to the last case. Nadine and Dr. Levine, please take it away.
Yes. Okay, so hello everyone. We'll be presenting our case for today. This is a 68-year-old patient who presented to our clinic with an MRI finding of a large sinonasal mass. I'll be showing his MRI shortly. His symptoms were a 5 to 6 month duration of a progressive left nasal obstruction with rhinorrhea and hyposmia, along with dizziness, headache, and diplopia. Previous past medical history that is a bit related to us is he had a nasal polypectomy outside the US and a tonsil and adenoidectomy. On exam, he had no neurologic deficit and his cranial nerves were intact. On scope exam, he had a highly vascular pulsatile nasal mass that was filling the left nasal cavity. However, this mass was extending beyond the middle turbinate, but not reaching the nasal floor nor the nasopharynx. And he had surrounding that watery polyps. This is his MRI. So as you can see, he has this large mass in the left nasal cavity, obstructing almost all of his left sinuses with intracranial extension as well, and abutting the left orbit as well. This is his CT scan to assess for any further bone involvement. His medial orbital wall did not look invaded, but he had some chronic bone changes, mostly in the sphenoid and in the clivus, and the roof of the ethmoid as well. We needed to get tissue biopsy to get further assessment of what this patient was presenting to our clinic with. But given the vascularity of the lesion that was on our exam and the anxiety of the patient, we were unable to have the biopsy in a clinic setting. And we could not also ask for a PET scan early on because the insurance company refused to get clearances before a biopsy-proven malignancy, which was highly suspected on those imaging findings. So we ended up taking the patient for an intra-op biopsy, and on frozen section, the patient had a malignant neoplasm that was suggestive of carcinoma. Thinking of what could be part of our differential diagnosis for a malignant nasal mass, these can be a long list, but if we want to name some of them, we have the neuroendocrine tumors, the pituitary adenomas, melanomas, lymphomas, SCC, SNOC, rhabdomyosarcomas, or even Ewing sarcomas. And if we want to compare neuroendocrine tumors to olfactory neuroblastomas, usually esthesioneuroblastoma, they have a less aggressive clinical course compared to the neuroendocrine tumors. So the pathology of our frozen section ended up being indeed an olfactory neuroblastoma, and it was read as a grade 3 on HIAMS. Basically, the HIAM grading system is what will be categorizing the pathology or the histopathology of these tumors based on their architecture of the cells that they have, and this will further give us information on the prognosis. With higher grades, meaning that the patient will likely have or present with metastasis, mostly in the neck, and will have a worse survival rate. These are our own patients' pathological slides. These were provided by our pathology department, in which you can see some of the clinical findings that points out to the olfactory neuroblastoma with the grade 3, and some of the key points or key cellular structures related to the diagnosis of the olfactory neuroblastoma. We have specific pseudo rosette in him as well. So my question for the panel are the following. What would you order for additional imaging for a patient that presents with such a scenario to your clinic? What are some of the referrals you might consider? And if his neck is negative, what would you actually do with the treatment of the neck?
Okay, maybe that's a good opportunity to stop and focus on some of these questions that you've posed here. Dr. Montero, maybe your thoughts on, let's focus on maybe the neck for now. He or she is N0, I believe, Nadine, is that right, on imaging?
So this is my initial question. Would you ask for imaging for the neck to start with?
Okay, let's say the imaging is done and it's negative. Eric, what are you doing for the neck? HIMS 3 or high grade HIMS? Are you doing an elective neck dissection? Are you observing the neck or elective neck irradiation? What are you thinking for this patient?
Sorry, right now I'm just trying to deal with my post-viral cough, which I think is becoming more functional in nature than actually pathologic. But yeah, so that's a good question, Nadine, and it's a topic of controversy, as many will talk about how to manage the neck. Generally, generally, we would not operate on an N0 neck in the setting of esthesioneuroblastoma. I don't know how my esteemed panelists, whether they would agree with that, but generally we would not approach that with primary surgery. However, where it's controversial is the radiation side of things and whether you give elective neck radiation to patients with N0 neck disease. There's been lots of studies on this, and in our study, actually, HIMS grade was not predictive of neck metastases. John can speak to this as well, but we did a study where there's actually comparable rates of neck failure in low grade and versus high grade HIMS. So we're not sure whether that's necessarily true. However, other things can predict regional failure. I think out of the Pittsburgh group, Eric can correct me if I'm wrong, but when you look at something like dural invasion, for example, is actually quite predictable of neck failure as opposed to HIMS grade. So our radiation doctors sometimes do treat the neck electively as part of management. About 20 to 25% of patients will fail on the neck over time, generally, I think was most of the studies have shown. And actually, the neck has also been shown to be relatively salvageable surgically. And when you add postoperative radiation to a previously non-radiated neck in the salvage setting, that can show some decent control options. So long answer is that we don't tend to treat the neck electively in these scenarios. However, the neck is often treated to some degree, whether that's microscopic radiotherapy dosages of 50 gray or more. It kind of is dependent on our radiation doctors. But I do tell patients that they do have about a 20 to 25% chance over time of failing regionally.
Kyle, how are you guys addressing the neck at Ohio State?
Yeah, great question. I think Eric brought up a lot of key points. And like you said, there's been several retrospective analyses that have looked at nodal failure rates. And like you said, for Kadish B and especially Kadish C disease, which this is, the risk of nodal disease or nodal failure is significantly higher. And so for us at Ohio State, we would routinely treat the neck with elective nodal radiation, and that allows us to include level 1 as well as the retropharyngeal basin, which is tough for the patients, but that can be pretty comprehensive there.
Yeah, in Toronto, we electively treat high-grade tumors, bilateral level 2, 3 actually, and RP nodes. We don't treat electively level 1. Eric, to your point about regional failure, there's actually a lot of data with elective nodal irradiation that the regional failure rate is very low. In fact, in the Michigan series and I think MD Anderson series with elective nodal radiation close to zero. That 20 to 30% is when you don't treat the neck. In fact, we did a neck dissection recently on a low Himes grade patient who recurred isolated level 2 in the neck. Marilyn, your thoughts on neck management? Is anyone doing neck dissections here?
Not for clinically negative neck. I agree with what's been said that because of the risk, especially in this patient with the intracranial extension, my radiation oncologist would radiate the neck because you can't really access those retropharyngeal nodes real well with elective neck dissection. You can't really argue to do an elective neck dissection when there's no clinical or radiographic evidence of disease. So, I think after the surgery, they would see our radiation oncologist who would very likely recommend post-op radiation, including the neck.
Yeah, sorry, John, I should have clarified that before, but yeah, I meant that 20 to 25% is exactly why most of our rad-ons give it, right? Because I think our data shows it's less than 5. We've had less than 5% failures with elective neck radiation, right? Which I think is similar to the Michigan data. I don't know if it's 0%, but I remember something between less than 6 or 7% was sort of the data, but I could be wrong.
And Dr. Levine, let's say this is a 20-year-old patient with a Himes 1 with the same volume of disease on imaging, so a low Himes grade esthesioneuroblastoma. What are you thinking at your institution in terms of managing the neck or not managing the neck?
Yeah, that's a great question. I think one of the great advantages is to kind of go through that at tumor board, and we'll often, have that discussion. This is a young person then who has a high volume of disease and a long life in front of them. And I think they really also need to be part of that discussion. We know that neck recurrence is one of the most likely areas and that can be very delayed in this pathology. So we do really want to make sure that they understand that if we decide not to do the neck, there's a possibility that this is going to be the recurrence. I did have a significantly younger person, I want to say 16 or 18, that had an esthesioneuroblastoma with a clinically negative neck. And after talking with the patient as well as the family and our radiation oncologist and looking at the intracranial extension, we did actually decide to do treatment to the neck as well. That was very much a discussion that they were involved with. But I do think that ends up being a much more kind of personalized decision and also a little bit focused on what kind of the risk tolerance level is of the patient and the family.
I think for the fellows, it's important that, in young patients, the bilateral neck irradiation doesn't come without side effects. And salvage rates on recurrent neck disease and esthesio are not small. What I mean by that is you probably have a 70 to 80% likelihood of salvaging a nodal recurrence. So that should definitely be a point of discussion if they recur. It's not like those are going to be catastrophic recurrences necessarily. They're very salvageable typically. So maybe Nadine, take us through what you guys did here.
So we did order imaging of the neck. We ordered a CT scan of the neck that showed a positive lymph node on the left. And we asked for also referrals to head and neck and neurosurgery for the extent of the disease in the neck end and through the skull base. As for additional imaging, we also asked for a DOTA Tate PET. And I want to talk a bit about this studying specifically because esthesioneuroblastomas are known to express somatostatin, and the DOTA PET scan is a somatostatin receptor targeted PET. It has multiple advantages over the regular FDG PET CT. Mostly, it has better resolution and accuracy. We have less radiation dose on the patient. It costs less, and it's much comfortable for the patient. Most of the time, it's used when the tumor is difficult to visualize, when we have extension through the brain or through the skull base. And with the regular FDG PET scan, usually with esthesio, these have low metabolic activity, so the PET scan might be falsely negative. So many authors now are recommending the DOTA Tate PET scan to detect lymph node metastasis rather than the regular FDG PET scan. So as all the panelists have been discussing with the N0 or the N1 neck, we all agree that with the N1 neck, the patient will undergo a neck dissection. Most of the literature also recommends radiotherapy after that, plus or minus chemotherapy, which I'll be asking you about that in a few minutes. And with the N0 neck, the literature also is being geared into going with the prophylactic radiotherapy to the neck, given the high rate of regional failures in patients who do not receive this elective neck radiation, even in those Kaddish stage B or C tumors. So this is the DOTA Tate PET scan of the patient. You can see the tumor involvement in here, and this is his neck scan. Next would be how would we stage our tumor? And we have multiple staging system. The most common one is the Kaddish versus the Dolgorov stage. We are mostly familiar with those stages. The Kaddish is less detailed about where the tumor actually invades versus the other staging system, which is the Dolgorov. It goes more into details of which entities the tumor is invading. This will also help us, if we follow one of those stages, let it be the Dolgorov, to know what approach the surgery should be or the surgeon should follow. And it will correlate with further assessment of this tumor based on the involvement of either the cribriform, the orbit, or the dura, which will eventually play a role in the risk of recurrence and the death over time. Versus with the Kaddish, mostly like the Kaddish stage C, will have all of the tumors grouped in a single entity, regardless of which structures they are invading. This is an interesting study.
For the sake of time, I think we can skip forward since we're a little slow for where we are to talking a little bit about the resection.
Okay, so this is in summary our tumor. It's a tumor that is invading the skull base. It has intracranial extension with meningeal enhancement and a positive neck. It is staged as a Kaddish D and a high M3 on pathology. So what would be your approach for surgery for this patient?
Maybe Nadine, why don't you show us what you guys did, and then we can get some feedback from the panelists.
Okay, so what we ended up doing is a combined approach with neurosurgery, going from above and below at the same time. This is our endoscopic view working on the ethmoid, and this is the above view. we ended up just like we would treat with any craniofacial approach, following the tumor, opening up the maxillary sinuses, the sphenoid, clearing it from different areas to get better access and to control the bleeding. So this is our endoscopic approach. This is the repair that was eventually done with the alloderm being sutured to the dura, and this is the immediate post-op CT showing the resection and the repair. These secretions are from the packing that were placed in the nose.
Can you just clarify, did you guys go from above with the craniotomy or everything entirely from below?
So this is the above procedure. So a craniotomy was done at the same time, press the tumor from the endoscopic approach.
Okay, maybe pull up your images and we'll get some feedback from the group. Dr. Wong from UPMC. Eric, your thoughts on combined craniofacial resection with endoscopic assist versus strictly endo approach here?
So, I mean, I think actually in our team, we probably would have done this purely endoscopic, but in truth, I don't know that it matters as long as you get an R0 resection from a margin standpoint. If your team is more comfortable using a craniotomy to achieve that, I think it doesn't matter. I mean, our team, we probably would have done this because it's behind enough, it's behind the frontal enough. It certainly has a reasonable lateral extension, but I think it's well within the reach of the midplane of the orbit. So we probably would have done this endonasal. I will say though, these surgeries are pretty long. So in my hands, I probably would have done the neck dissection actually on stage one. And I like to do the neck first because I don't really love reintubating my fresh open craniofacial resection or endoscopic craniofacial resection with the reintubation of the neck. So I tend to do the neck first because I think it's a pretty straightforward operation. It's at least the node that you showed, Nadine, was pretty significant in size. So I would have at least done the left neck first and then probably done an endoscopic craniofacial resection for clearance.
Marilyn, your thoughts on when to do a craniotomy versus indications for a craniotomy versus endoscopic approach?
Yeah, Karina, how did you reconstruct the defect? Did you use a pericranial flap or nasoseptal flap? Because that is one of the things we think about in deciding on the approach.
There was no nasal septal flap that was going to be available because of the involvement with the sphenoid and the extension. We knew we wouldn't have one.
Yeah.
And the I think one of the things that is an advantage here that you don't get to see is that for us, when we talked to the patient and I took him for an intraoperative biopsy, I said, well, if we know that it's something that we expect to be resectable, I can debulk some of it at the time. So when you can breathe into our second stage surgery will be much faster. So I think Eric's point is excellent. And for us, this was about half the size of what you see by the time that we went to do the second stage, where we did it from above and below. And then we actually did the neck all in the same day. And because we do above and below at the same time, we actually work simultaneously. So that saves us a lot of time to do it that way. But I think that's part of the reason is that we knew we wouldn't have a nasal septal flap. This is an older gentleman, and so this was a pericranium flap that we used.
Yeah, I think that would definitely weigh into the decision. I think that the tumor itself looks accessible and resectable from below, but if there's a concern about reconstruction, it's good to have that option of coming from above, so you can do the pericranial flap.
Karina, correct me if I'm wrong. I imagine you guys chose to go from above because of that dural enhancement that goes almost to about the pupil on the left-hand side. Was that because to me, you kind of scrolled
Part of
over,
it.
it looks like the dural enhancement goes about to the level of the pupil, but maybe I'm just right there a little
Yeah.
bit back. So is that kind of what tipped your neurosurgeons? Because that's hard to get endoscopically if it really does go towards the pupil and beyond.
Yes, and I think that our concern was that we wanted to make sure that we got good margins on him. We definitely wanted to get a good resection, and we were worried that if we were there and struggling and then we had to stage it versus doing it all at once, we really felt that then we got a better reconstruction, we got a better opportunity to get the really good resection for him, and then to make sure that we can really get him to radiation. Sometimes we will do this at Miami with just an alloderm reconstruction and no, vascularized covering there. But if we're going to try to get him as an older person to radiation quickly, and we knew that we would want to do that, this was, I thought, just a better option for him in general.
And then I guess a quick second question is the fiber osseous appearing bone throughout the entire skull base. Did you biopsy that just to confirm that that was a separate fiber osseous lesion, or how did you manage that?
Yeah, so he definitely has a whole bunch of fibrous dysplasia, and so a lot of it does come back as fibrous dysplasia, but we also then had to drill quite a bit of that bone to get kind of all the stuff that was in the nooks and crannies, which was less than pleasant.
Okay, Kyle, final word. Combined crani endo versus endo alone and reconstructive options at Ohio State.
Yeah, great question. I think if you go through that MRI, the one thing that kind of leans me slightly towards the combined approach, in addition to the reconstructive ability, because you're going to need a pericranium either way, is that the tumor has a fairly narrow waist right there that you're kind of working through, and then it kind of mushrooms out. So you're going to be fighting with that right frontal lobe quite a bit endoscopically, and you're going to be able to manage that perhaps a little bit better in an open approach, and then the extension up over the orbit on that left side. So, we might start endoscopically and then after we've struggled long enough, decided to go open, or maybe just plan for it straight ahead of time. Frankly, I think, it depends a little bit on the patient's age and all those things. This has been noted, but I would perhaps lean a little bit towards a combined approach here.
Okay, I want to take this time just to thank everybody. We ran a little bit over. Thank you to all the fellows, first of all, for some great presentations, the faculty mentors, and of course, our senior discussants. Actually, I'll take that senior away, but I'll just call them discussants. I don't want to falsely label anybody, and turn it over to Tony.
That was an incredible session, and just kind of wanted to thank everyone again, and also remind you of the next session. We talked about open and endoscopic approaches to the skull base today. Our next session is about open and endoscopic approaches to the larynx, and that'll be on April 2nd. I've put it in the chat there, and it's in short order only because we moved this session over because of the North American Skull Base Society and other conflicts. But really looking forward to seeing all the fellows over for that one. And the cases today, the quality of the discussion, the quality of the cases was absolutely incredible. Complexity was extremely high, and it felt better than most tumor boards, to be honest. This was just really exceptional. So great job, everyone. And thank you, John, for organizing. See you guys all on April 2nd.
Yeah, thanks so much, everybody.
Thank you.
Thank you all.